So, good morning, everybody, and bon appétit for those who are happy to have lunchbox. And it's a great pleasure for me to be here today, trying to promote this kind of recommendation. It was good discussions, and we hope we will give you some valuable information that will help you and help us improving care in those patients. In my part, I will deal with the induction of anesthesia, so a very specific part of our daily practice. First of all, my conflicts of interest, my disclosures, just to show you that I have some conflicts of interest. So we are going to discuss around a specific clinical case, just for the discussion, and I propose you to think about the case of this 65 years old man, age quite normal, quite common weight, which is scheduled to be operated from an abdominal surgery for a cancer colon. His medical history, as you can see, is very common, just hypertension, type 2 diabetes, and no recent or past history of respiratory disease. His clinical examination did not report anything specific. As you can see, pulse oximetry 95% in room air, and also laboratory samples are within normal limits. So my first questions for you is, what is your estimation of the risk of postoperative pulmonary complication in these patients? So you have 15 seconds. Is it very low, less than 1%, low, less than 5%, moderate, or high risk for postoperative pulmonary complication? Very common case, I hope. So for most of you, almost 50%, this patient is at low risk for postoperative pulmonary complication. So as you can see, it's sometimes very difficult to evaluate the risk of the patients, especially when these patients are very common, and that's why we believe it might be interesting to use predicted score. And one of these is the ARICAT score, and when you put all the conditions of this patient and when you use the ARICAT score, you can see that in fact this patient can be considered at intermediate risk of complication, which means that the incidence, the anticipated incidence of postoperative pulmonary complication is all around 30%. So intermediate risk of complication, not very low, not low, but intermediate risk of complications. And we made the recommendation to use a dedicated score, and we believe that this should be helpful to better evaluate or to assess the risk of complication in our patient than au doigt mouillé, as we say in French, because it's sometimes against something difficult to evaluate the risk. The second question, how would you improve general anesthesia induction in this patient? Are you going to use reduced concentration of inspired oxygen, specific position, the beat share, the flat supine, and are you going to use NIV for the pre-oxygenation, for example? Again, 15 seconds. What do you think about that? Okay, interesting. Almost 50% will use NIPPV. Are you already using NIPPV for the pre-oxygenation in this patient? I'm not quite sure, but we'll see. Brave, you know that anesthesia, and especially anesthesia induction, is responsible for some modification within the lungs, especially a reduction in lung volume. And FRC is one of the most important to consider. There is also a decrease in lung compliance and sometimes an increase in resistance. And all these modifications will prone the patients to airway closure and the atelectasis formation. So it's important to have this in mind. And this is especially true in obese patients, which are much more common in daily practice as the volume, the BMI increase, the risk of reduction in lung volume increase. So we have to consider this in our patient, especially if they are obese. And obviously, when you put the patients from supine to head-up position, especially the beach chair position, you will have some positive effects, one of which is the increase in the duration of non-hypoxemic apnea duration, which obviously will increase the duration in case of a difficult and unanticipated difficult tracheal intubation. And that's why we made the recommendation to position the patients in the beach chair position, which means around 30 degrees, and to avoid, obviously, the flat supine position. And this position will, as we can see, improve our condition for intubation. The second recommendation is to use NIPPV during pre-oxygenation. You can use either NIPPV or CPAP. And this should be considered as useful adjunct during anesthesia induction in almost all our patients. And you know, I'm quite sure that PEEP will be very useful in this situation just because it will again increase the duration of non-hypoxemic apnea duration by almost 50%. So it can be useful in some patients, especially if you don't anticipate it again, the risk of difficult mask ventilation or tracheal intubation. And obviously PEEP, the use of PEEP will also decrease the proportion of atelectasis within the lung. So the use of NIPPV, especially when using PEEP, can be useful in some patients. But again, keep in mind that as soon as you remove the mask, the effect of NIPPV will probably quickly disappear, and it can be useful in some patients, at least in obese patients, to consider recruitment maneuver after intubation, but this is another question. The third question: which ventilatory mode will you propose as first-line therapy in this patient? Will you prefer using volume control ventilation, pressure control ventilation, or another mode? Again, 15 seconds for you. Your first line choice. Okay, interesting. 16% will propose other modes. I don't know exactly which mode is it, but 16% other. So the recommendation is that there is no specific mode to promote or to recommend during mechanical ventilation in daily practice for patients during surgery. And there is a common misunderstanding or misinterpretation between pressure control and volume control, just because usually some physicians consider that the pressure will be lower in pressure control than in volume control, but in fact, for the same level of assistance, the level of pressure are exactly the same. So that's why some people consider that we should apply pressure rather than volume control ventilation, but in fact, this is exactly the same. So no reason to promote a specific mode to another mode. The fourth question: how would you set initial ventilator setting in this patient? Again, a patient, you have the height and the weight. Would you use a tidal volume of 600 milliliter, 500 milliliter? Will you use PEEP and FiO2, 100%? Five seconds last. %60 people 5. Great. And nobody, see, yes, 1% will use 100% FiO2. Obviously, when you're going to apply the lung protective mechanical ventilation strategy, you are obliged to consider to reduce the tidal volume, but also to apply PEEP in order to avoid both overdistension and trauma. So the concept of lung protective ventilation should be or is the association of reduced tidal volume and PEEP, and to avoid higher tidal volume and obviously zero PEEP or VEEP. So that's why we recommend, based on the most available data, to set the initial tidal volume below 6 to 8 milliliter per kilogram predicted body weight, and it's important to keep that in mind. Tidal volume should be set on the predicted body weight, not in the ideal or actual body weight, sorry, and to apply a PEEP of 5. So the first PEEP for every cases is probably 5 or around 5, but we recommend to apply 5 as beginning, and then to individualize PEEP in order to avoid any increase in driving pressure, which is the difference between the plateau and the peak pressure, while maintaining obviously a low tidal volume. And this is why, because you know that even in patient during surgery and even in patients with healthy lung, any increase in plateau pressure or in driving pressure can be associated with an increased probability of developing post-operative pulmonary complications. So we have to consider to apply settings which are going to be associated with a low plateau pressure and a low driving pressure. The last recommendation following intubation, obviously no reason to apply the 100% oxygen, and we recommend to apply the lowest possible FiO2 as soon as SpO2 is higher or close to 94%, and we don't need to have 100% pulse oximetry, obviously. As you know, no reason to apply high concentration of oxygen because there are absolutely no beneficial effect in terms of reduction of surgical site infection. But in contrast, high concentration of oxygen and hyperoxemia can be deleterious in some patients, especially because it can create some vasoconstrictions and again can be dangerous for some patients. So no reason to apply high concentration of oxygen in almost all patients. So to conclude the summary for this part, we consider that it's useful and we recommend to use a dedicated score to assess the risk of pulmonary complication in patients in daily practice. The head-up position can be useful to increase the duration of non-hypoxemic duration of apnea, so please consider the use of this kind of position. Consider also the use of NIPPV or CPAP for the pre-oxygenation phase, at least in high-risk patients, but in my opinion, in almost all patients. Whatever the mode, the tidal volume should be set below 6 to 8 milliliter per kilogram per decibel weight with a PEEP of 5 at the beginning, and then adjusted PEEP regarding some specific patients. And following intubation, the lowest FiO2 should be considered in order to achieve pulse oximetry higher than 94%. Thank you.